मैं मजीद टाइम जाए किए बगैर आपकी भरपूर तालियों में नेक्स्ट स्पीकर, ऑनरेबल स्पीकर जनाब फारूक खान नियाजी साहब, जो पॉलीसिस्टिक ओवेरियन सिंड्रोम पे आपके साथ अपने ख्याल शेयर करेंगे। आपकी तालियों में जनाब फारूक खान नियाजी साहब, प्रोफेसर डॉक्टर फारूक खान नियाजी साहब। इसके बाद इंशाल्लाह लंच का वक्फा होगा, और अगर किसी बंदे ने लंच का कार्ड नहीं लिया तो वो रजिस्ट्रेशन डेस्क से और ऑर्गेनाइजेशन से ऑर्गेनाइजर जो हमारे यहाँ पे मौजूद हैं उनसे रब्ता करके अपने लंच का कार्ड जरूर ले लेंगे। उसके बगैर एंट्री वहाँ पे नहीं होगी। हाल में डॉक्टर फारूक खान नियाजी साहब।
Was in touch with him when I was in Karachi at Pina Shifra, and he is a great teacher, and you've seen how he keeps you awake during the lecture, and that's what a good teacher we should learn from. Fazil and Dr. Musarrat has covered whatever I'm going to tell you. But what I need to stress is the concern about polycystic ovarian syndrome and the diagnosis. You all know that this is one of the things that we all should know, and the ladies who are sitting here and all the men, that we have daughters, and nobody would love to see his or her daughter suffering from this dreadful disease. So the early diagnosis plays a very, very important part. So ठीक है जी, हम इसको खरीद कर। Well, this was described in 1935, seen in Lemonfall, and its incidence is 5 to 10%, but I believe that we have almost 25%. Secondly, we have so much common. This syndrome is getting worse, and because we are not aware of it, or we do not, people don't come early to the clinicians and to the smologist. It is the leading cause of female infertility, and insulin resistance associated with this disease was described very late in 1980. So the syndrome consists of polycystic ovary, all ovaries, both ovaries or one ovary, amenorrhea, hirsutism, and obesity is really the one which is significantly related to this disorder. Now, as we call it a syndrome, we don't know the cause. We don't know exactly what happens, but we know how it happens. It's usually the increase in luteinizing hormone secretion and decrease in follicle stimulation hormone. And that leads to impaired development of the follicle, which leads to anovulation or a lesser number of egg formation, and which in turn leads to increase in the testosterone levels and hyperandrogenism. Now this hyperandrogenism is the one which skin specialist knows it better, and some other we have a deficiency in working in teams, especially in this part of the world that I have landed from Karachi. Karachi was, we used to work much in a team rather than this place. And I am always encouraged that it's a team effort. The hirsutism, acne and alopecia, they are disorders. The skin specialist doesn't refer for an ultrasound or to the gynecologist timely to look for this syndrome. Hyperinsulinemia occurs with insulin resistance that I have already told you, and then the obesity has interlink. The extraglandular aromatization, whenever you see a girl of 8 years and having bigger breasts and unusually larger fat in the subcutaneous areas, you should suspect, and one should think of this disease. Now, this already has been adequately elaborated by Dr. Tazi. The normal ovary produces primary follicle, secondary and mature follicle, ruptures and becomes a corpus luteum. If it doesn't, the pregnancy occurs, then it becomes a corpus luteum, which holds the pregnancy for 12 weeks till the placenta takes over. But something goes wrong somewhere here in the development of the egg, and the multiple immature follicles are the ones which appear as stromal cysts. Now, Dr. Musarrat had already stressed the need to see the central stroma, which is echogenic, and we should look for that clue also. Now, in a normal menstrual cycle, this surge of LH causes the ovulation, and in PCOS we have a flat LH, raised flat LH levels. Clinical presentation, obesity accounts for almost 50% association, and 50% of patients with PCOS have obesity. PCO, इसका मतलब ovaries have cystic appearance, is in 80% of cases. That means that you can have 20% which will not have polycystic ovaries. But insulin resistance, oligo-ovulation, oligo or anovulation, androgen excess and hirsutism all go by almost 70%. Now, if you notice that due to the increased androgens, hirsutism and acne and androgenic alopecia can occur, and our ladies, मेरी बहनें और बच्चियां जो हैं वो इसको छुपाती फिरती हैं और चाहती हैं किसी टूटे कर ज़्यादा इस्तेमाल होते हैं इसके लिए. But it is so bad, and in our hair society in Multan that I have seen that people cover their heads, they are more modest and they're doing it. They try to, they don't try to uncover them and show to the doctor even. Menstrual irregularity, 70 to 75% they are oligomenorrheic, amenorrhea associated with 20%, and infertility in 30 to 70%. That means that we can still have pregnancy with the PCOS in some percentage. So obesity is the one. Now you can see that these acanthosis nigricans, the folds or neck or armpits, are also very annoying, and they don't go with any skin treatment. And then you have, if you see skin tags like this in excess in a child or in a bit obese woman, one should think of PCOS. When you assess the hirsutism, these are the parts, 9 parts, which are scored 1 to 4 in the grade. And if they have more than 6 number, you can see the upper lips will have a few hair to well-developed mouth stretches, a few hairs at the chin and jaw to a well-developed beard, central chest hair growth, central abdominal growth, the pubic hair becoming more like male, and you have an armpits growth, then high hair growth, back of the thorax, and over the buttocks and back of the lower spine. Virilization is another thing, but if you notice a collateromegaly or a voice sleeping, patient should be referred for investigation of PCOS. Again, repeating the same so that you can remember these things. Because of the signs of androgen excess, you have hirsutism, acne, male pattern of hair loss, upper body muscle mass, people become more fat or muscle become increased. Collateromegaly is one thing. Then amenorrhea, oligomenorrhea, and dysfunctional uterine bleeding is the one of the symptoms. So ovarian enlargement, we'll discuss it later how we assess it. Endometrial hyperplasia is tricky because in young female you can have endometrial dysplasia without PCOS. So we should not overshoot the diagnosis, but we should not neglect the diagnosis. Obesity, acanthosis, I have already told you, elevated blood sugars, elevated insulin, and hyperlipidemia, cholesteremia. Polycystic ovaries, for polycystic ovaries and PCO, TVS remains the best choice. And here I would say the gun becomes more important, mostly not the one who is behind the gun. Your machine becomes more important. Your TVS probe becomes more important. And your technique, of course, is important. The incidence decreases with age. And you can divide the PCOS in 3 brackets. One is an adolescent stage, this other one is the menstruating woman, and the third is premenstrual, premenopause or menopause stage. So rule of 20 goes with this. 20% of women with PCO have PCOS. So not many. In that case, if you find polycystic ovaries, just not jump to a conclusion. Only 20% will have PCOS, but it should be highlighted, and a clear understanding is important. As Dr. Musarrat and Fazil Rahman has already highlighted, the mature follicle. When you see a mature follicle, then you have to have a follow-up. You must have a follow-up to declare it polycystic ovaries, or you need to go for detailed investigations. But when you are doing an ultrasound, the patient is exposed to you. So you need to see the hairs. That's why I stress that you should see the abdominal hairs, and you can ask the patient to go to the concerned clinician. PCO evaluation also demand that you should have concept why something like any other differentials should be considered. And that's why I always stress that abdomen should be taken as a full abdomen. It should never be done in isolation. Upper abdomen, your lower abdomen ko pehle nahi karna chahiye. Whenever you are seeing a patient, you should do it, whether he is paying you or not. Whether he is paying you for just for a Doppler or not, you must see. And you should see the whole abdomen. You might see adrenal mass, a renal mass, or any pathology which can give you a clue. So early diagnosis is important. You can talk to the patient, see the patient if she looks like a cushingoid. And ovarian tumors should be investigated never do an ultrasound without a overfull bladder or an underfilled bladder. You can wait, patient should wait. For the benefit of the patient, I have seen people giving opinion on underfilled bladder or an overfilled bladder and missing out a very simple thing. Transabdominal scan is fairly good, but it can show you ovaries, it can show you that the ovaries are enlarged, but you see when the bladder fills up, the volume is not exactly measured. The number of follicles or number of cysts in the ovary would not be clearly seen. So you should go for TBS, and if you can't go for TBS, you can go for transrectal ultrasound, or then you can go for an MRI pelvis. That can give you an idea of what is happening with this patient. You can see that the TBS examination gives you clear size, and you can count them. And if you have a good machine like Dr. Farooq has, and he can you can count the follicles and these cysts, then the criteria that I'm going to tell you is will be fulfilled. Two out of three these things, androgen excess, this can be assessed by clinical, by looking at the patient, and biochemical profile. Ovulatory dysfunction, you all know that you will have a lesser ovulation or no ovulation. And the polycystic ovaries can be seen by ultrasound when you have 12 follicles of 2 to 9 millimeters, the volume more than 10. Now, exclusion with other etiologies, I have already told you that when you are doing an ultrasound, you can do a thyroid profile, thyroid examination, and you can look for the sign of acromegaly or any other cause of the symptoms. Now, the second is when this was in adults, so this is in adolescence, hair and evolution and polycystic ovary is not reliable, and here you can have these three things. Exclude the other etiologies, persistent oligomenorrhea and androgen excess. So suspect करें जब 2 साल तक मिनाकी में आपका बेटी या बेटा ना जाए तो उसको सस्पेक्ट करें एंड उसको पूरा इन्वेस्टिगेट करें, उसको ऐसे ना छोड़ दें, बिकॉज अगर ये शुरू में पकड़ ली आपने बीमारी तो यू विल बी एबल टू ट्रीट इट, बहुत बेहतर कर लेंगे। और उस पर क्या फैक्टर्स हैं मैं इस पर भी स्ट्रेस करता हूँ आगे। The other is pre-menopause and menopause phase. इसमें long-term oligomenorrhea and hyperandrogenism होता है, so polycystic ovary is very unlikely also in this group. Now transvaginal ultrasound के तो आपको बता दिए, but नई एक जो चीज अभी आई है वो ये है कि अच्छी मशीन्स के ऊपर we can see the volume का उतना बेहतर आउटकम नहीं है। So 25 follicles per ovary, superseding the earlier criteria था, now it is up to 25. So you can see all around by a TBS probe or a 3D or 4D probe. Now central stromal brightness already stressed, ovarian enlargement more than 10 mm. Only one ovary is sufficient to define PCO, remember, and there is evidence of dominant follicle 10 more than 10, or a corpus luteum is seen, wait and repeat the scan in next cycle. A study published in 2013 was specifically criteria for diagnosis of PCO. Follicle numbers per section or ovarian volume were studied, and it showed that for follicles number per ovary threshold of 26 follicles had sensitivity of 85 and specificity of 94%. And FNPS, that means per section, 9 follicles had up to 9 follicles or 12 follicles, 69% sensitivity and 90% sensitivity. So ovarian volume is a poor indicator, and 81% sensitivity and 84% specificity. So remember, volume is not that important, it's the number of cysts that you see. Due to lack of consensus on this part, many books, many places, different criteria is developed, but it's easier to report when you report the follicles in each ovary rather than attempt to label the ovaries as polycystic or multicystic. PCO is not a normal variant. It is a mild phenotype of PCOS. Please remember this. Now, what is our role as a radiologist or a sonologist? We need to know PCOS very well, criteria of PCOS, and report the status of the ovaries to be specific. It should not be vague report. It should be coming to a conclusion, help the clinician. Ovarian volume should be given. Antral follicle count, dominant follicle size should be mentioned. If corpus luteum is seen, it should be mentioned, and repeat scan should be done. And renal and adrenal status should also be looked for on ultrasound. Repeat ultrasound if advised. If TVS is not possible, as I already said, repeating to transrectal ultrasonography can help, and MRI pelvis is indicated in cases, especially in adolescents and obese patients, when you cannot see on TVS. A good quality machine is very useful in skilled hands. Now, patient pertinent reporting parameters for PCOS are: you must have a history, age, last menstrual period, and the scan should be done in 3 to 5 days of the menstrual cycle. You should ask and mention the patient is on oral contraceptive or drugs or fertility drugs. Ovarian finding should be separately reported for each ovary. Each ovarian number, size should be given, number and size and range of the follicles, and size of the largest follicle should be mentioned with average calculated. Any follicle more than 10 or corpus luteum, again repeat ultrasound. Ovarian volume should be calculated by ellipsoid, easy calculation. Now, the most important thing that I would stress is weight loss, which can, with just to 5 to 10% of weight loss, can restore the ovulation in more than 55% of cases in 6 months. This study was done by somebody named Kitty in 1992. So 92% resumed ovulation, and 85% became pregnant. So 10 signs of the symptoms, again, just revising. On the left side: irregular periods, absence of menstruation, excessive facial and body hair, hair thinning or loss, and abnormal skin pigmentation. High blood sugar, weight gain, acne, and all these things add up to depression, stress. As Dr. Musarraf gave many 5s, this is 5 factor which you can prevent your kids, female kids, and please note them, because bad dietary choices is one of the leading causes now जो आपके बच्चों को खराब कर रही है. ये KFC बढ़ता जा रहा है, और KNN जो है वो भी is not a healthy proper way. It's not a healthy food. So आप उसको बहुत ज़्यादा आदी करेंगे कोल्ड ड्रिंक्स का, बहुत ज़्यादा करेंगे तो toxins. Stop eating junk food. So मेरे अपने ख्याल से we are all parents, or हमें इसलिए ख्याल रखना चाहिए कि हमें 7 साल की उम्र से लेके when the लड़की की मनाकी होती है, it is at that time that mother and father has to cut and check the girl's diet. अगर आप उस वक्त डाइट नहीं चेक करते हैं तो उसकी सारी जिंदगी तबाह होने का खतरा है। और बहुत लोगों का ऐसे हुआ है, मेरे अपने दोस्तों में बहुत सारों में मैंने देखा है। And fortunately my wife, being a doctor, she has taken care of that, and she does, and my daughters have been checked of becoming, they are more skinny, they should be more skinny at that time, because if you बच्चों को आप दे रहे हैं खाना, यदि लड़के भी खाएं तो लड़कियां उस वक्त मुकाबला कर रही होती हैं कि मैंने ये खाया तो बेटे भाई ने यूं खाया। और आप अपनी आसानी से ये प्रोफेशनल, जितनी डॉक्टर मेरी बहनें बैठी हैं, आप भी अपनी प्रोफेशनल कमिटमेंट की वजह से कहते हैं चलो बर्गर ले लेते हैं, आज भी रास्ते से कुछ उठा लेते हैं, तो आप अपने बच्चों को प्रोन करेंगे इससे। एंड दिस वी स्टिल डोंट नो व्हाई इट हैपेंस। आई हैवंट शोन यू द ड्रेडफुल पिक्चर्स ऑफ वुमेन with mouth stitches and beard, but it's so painful to see somebody. And please take this message home, that we must check the diet and we must go to the doctor or send these patients to the concerned specialist. Thank you very much.